Have you ever met someone who just seems incredibly friendly, almost like their default setting is just open?
Yeah, like just naturally super approachable.
Exactly. Well, it turns out that sometimes that very open, engaging personality can actually be a clue for a rare genetic condition. It's called Williams syndrome.
Hmm.
And that's what we're diving into today. We had a listener ask about rare genetic disorders, and Williams syndrome is, well, it's a really fascinating one to explore.
It really is. And we've got some excellent pediatric revision notes here as our base. Think of it as the core info, the stuff you really need to grasp.
Right.
Our aim today is to unpack that, make it clear, and hopefully make it stick.
Yes, that's the mission. Take the key details, build a framework that's easy to remember, whether you're studying for something like the MSRA or just curious. So let's get started. What is Williams syndrome fundamentally?
Okay, so at its core, Williams syndrome is a rare genetic disorder. The root cause is a tiny bit of missing genetic material, what we call a microdeletion on chromosome 7.
A microdeletion.
Yeah, but don't let micro fool you. Even though it's small, this deletion has pretty broad effects across the body.
Okay. And if we think about the main characteristics, what are the sort of big buckets to keep in mind?
Well, you've got a characteristic facial appearance. We can talk more about what that looks like. Then there are often significant heart and blood vessel issues.
Right.
Also, a spectrum of learning differences. And as you mentioned, that really unique personality, that hypersociability, that intense friendliness.
Are there other names for it?
Yeah, you might hear it called WS or Williams-Burren syndrome, WBS, or sometimes just by its genetic location. Chromosome 7q11.23 deletion syndrome. They all mean the same condition.
Got it. Okay, so that's the what. Let's dig into the why. What's the etiology? How does this microdeletion actually happen?
It comes from a spontaneous deletion on that specific part of chromosome 7. And what's really key is that this area includes the gene for elastin.
Elastin, like elasticity.
Exactly. Think of it as the protein that gives tissues their stretch, especially important in blood vessels. Now, this deletion usually isn't inherited, it just happens randomly during the formation of sperm or egg cells.
So like a random genetic typo.
Pretty much, yeah. A one-off event in most cases.
Okay, so if it's random, are there any known risk factors, things that make it more likely?
No, not really. As far as we know, there are no specific risk factors. It just seems to be a chance event during conception. Things like parental age or lifestyle choices don't appear to play a role.
Wow, random, but with significant effects. Let's talk pathophysiology then. How does losing this tiny piece of chromosome 7 lead to all these different features?
Right, this is where you see the domino effect. Losing that segment means several genes in that region aren't working as they should, or they're missing entirely. The elastin gene loss, like we said, is a big driver for the cardiovascular problems.
How so?
It can cause a narrowing of the aorta, the main artery leaving the heart, just above the valve. That's called supravalvular aortic stenosis, or SVAS.
SVAS.
And other heart defects, too. It's quite amazing how losing just that one set of instructions for elastin causes such specific problems.
So the heart issues are strongly linked to that missing elastin gene.
Very strongly. But it's not just the heart. The genetic changes affect how various organs develop and function. They also contribute to the intellectual disabilities, that unique cognitive profile. And even those distinctive facial features we mentioned. It's a multi-system thing.
The source material gets a bit more technical on the genetics. Can we unpack that slightly? The hemizygous deletion part.
Sure. Hemizygous just means you only have one copy of that gene region instead of the usual two, because the copy on one chromosome 7 is deleted.
Right.
This deleted segment is usually about 1.5 to 1.8 million base pairs long. Sounds like a lot, but it's small on a chromosome scale. This specific area is often called the Williams-Burren syndrome critical region, or WBSCR.
And the elastin gene, ELN, is in there.
Exactly. ELN is a really important gene within that WBSCR. Its absence is also very strongly linked to something called infantile hypercalcemia, high calcium levels in babies.
Oh, interesting.
Yeah, apparently over 99% of infants found to have that high calcium also have this specific gene deletion.
So how do doctors actually confirm this diagnosis? What tests do they use to find that missing piece?
The main investigations are genetic tests. One common technique is called Fleisch fluorescent in situ hybridization.
Fishish.
Yeah, think of it like using tiny fluorescent probes that are designed to stick to that specific region on chromosome 7. If the region is missing, the probe won't stick, and they can see that under the microscope.
Clever.
Another key method is deletion duplication testing, often using microarray technology. This can look across all the chromosomes for missing or extra pieces of DNA, and it's very good at detecting the specific Williams syndrome deletion.
Okay, so let's say a child presents with some suggestive features. Before landing on Williams syndrome, what else might be on the differential diagnosis list?
Good question. There are a few other conditions that might share some overlapping features. Down syndrome, for instance, also involves characteristic facial features and developmental delay.
Right.
DeGeorge syndrome, or 22q11.2 deletion syndrome, is another, as it can also involve heart defects and some facial differences.
Okay.
And sometimes the social communication challenges might make someone think about autism spectrum disorder. But the social profile in Williams syndrome is usually quite different, often very sociable, but maybe lacking some social nuance, whereas in ASD you might see more social withdrawal or difficulty initiating interaction.
That's a really important distinction. Okay, zooming out a bit, epidemiology. How common is Williams syndrome?
It's definitely considered rare. Estimates vary a bit, but it's thought to affect somewhere between 1 in 7,500 and 1 in 20,000 live births.
And does it affect certain groups more than others?
No, it seems to affect males and females equally, and it's found across all ethnic groups studied. Although it's technically an autosomal dominant condition, meaning one copy of the deletion is enough to cause it, almost all cases are de novo.
Meaning new.
Yes, new in that individual. Their parents don't have the deletion, so it usually appears out of the blue in a family.
Right.
The notes give a couple of specifics, like in the UK, that infantile hypercalcemia, which is closely linked, occurs in about 18 cases a year. And a prevalence study in Norway put Williams syndrome at about 1 in 7,500, which fits the general range.
Okay.
Oh, and one point, while prevalence is equal between sexes, there's maybe some indication that males might experience more severe cardiovascular issues or earlier onset, something to keep in mind.
Good point.
Yep.
Okay, let's move to the clinical presentation. What does Williams syndrome actually look like in a person? What features would make a clinician suspect it?
Well, it's usually a collection of features rather than just one thing. Let's start with the facial appearance, as it's often mentioned. People often describe it as sort of Elfin-like.
Elfin.
Yeah, typically a broad forehead, maybe puffiness around the eyes, a small upturned nose, a long philtrum that's the groove between the nose and upper lip, a wide mouth, full lips, and maybe a small chin.
Okay. A useful memory aid might be to picture a friendly elf face.
Yeah, maybe. The friendly part fits the personality too, but focusing on those physical features, that's one part of the picture.
And internally. We know the heart is a big one.
Absolutely. Cardiovascular problems are very common. That supravalvular aortic stenosis, SVAS, the narrowing above the aortic valve, seen in around 75% of individuals.
3/4, wow.
Yeah. And also, particularly in babies, peripheral pulmonic stenosis, or PPS, that's narrowing in the arteries going to the lungs, is also pretty common.
Okay, so SVAS and PPS are key cardiac features. Maybe a mnemonic like supravalve aorta narrow for SVAS.
Yeah.
And pretty pulmonary small for PPS.
Hey, whatever works. Those are definitely high-yield points.
And cognitively.
Intellectual disability is usually present, but there's a range. It can be mild, moderate, or sometimes severe. It's worth noting, though, that some individuals can have IQ scores in the normal range, although that's less typical. Developmental delays are almost universal.
And the personality, we keep coming back to it because it's so striking.
It really is. That overly friendly, highly empathetic, very talkative nature is characteristic. They might strike up conversations with anyone, but it's complex. Alongside that, they often experience significant anxiety, generalized anxiety, specific phobias. Attention difficulties like ADHD are also common.
So very sociable, but maybe struggling underneath with anxiety or attention.
Exactly. And despite the talkativeness, they can have difficulties with pragmatic language, the nuances of conversation, and sometimes understanding complex language.
What about physical growth and musculoskeletal system?
Often there's prenatal growth deficiency, meaning they were small before birth. Failure to thrive in infancy, difficulty gaining weight is common too. They tend to end up with short stature as adults because of slower growth. Musculoskeletal signs can include things like joint hypermobility, being very flexible, or sometimes joint stiffness, soft, doughy skin, and often a hoarse or deep voice.
Any other physical signs mentioned?
Yeah, things like hernias inguinal or umbilical are more common. Outpouchings in the bowel or bladder called diverticulae can occur, even rectal prolapse sometimes, and feeding difficulties in infancy are a very frequent challenge.
Okay. What about other body systems? Endocrine, maybe?
Yes, endocrine issues can pop up. The big one is that idiopathic hypercalcemia, high calcium in the blood without a clear cause, sometimes with high calcium in the urine too, hypercalciuria.
Right, the calcium link again.
Exactly. Also, an increased risk of hypothyroidism, an underactive thyroid gland, and sometimes early puberty can occur.
You also mentioned a specific cognitive profile earlier, strengths and weaknesses.
Yeah, this is quite characteristic too. Often, individuals with Williams syndrome show relative strengths in verbal short-term memory. They might be good at repeating things back, and often strong expressive language skills like a rich vocabulary,
Okay.
but they typically have significant weakness in visuospatial construction. That means tasks involving spatial awareness, like drawing, copying shapes, assembling puzzles, or even map reading can be really challenging for them.
So, maybe a memory tip. Strong with words, struggles with where things are in space.
Sort of, yeah. Strong verbal memory, weaker spatial skills. That's a common pattern.
So, putting it all together, it's this combination of the facial features, the heart issues, especially SVAS, the developmental delay, the unique friendly but anxious personality, and that specific cognitive profile. That's what suggests Williams syndrome.
Precisely. The notes emphasize that diagnosis usually relies on recognizing this pattern of features. No single feature is absolutely required, but the combination is highly suggestive.
Okay, so if that pattern is recognized, what are the definitive investigations? We touched on genetic testing.
Yes, genetic testing is key for confirmation. Chromosomal microarray analysis is really the gold standard now because it can precisely detect that microdeletion on chromosome 7q11.23.
Microarray. Got it.
But because the heart is so often involved, cardiac evaluations are essential right from the start. An echocardiogram and ultrasound of the heart is crucial to look for SVAS, PPS, and any other structural issues.
Makes sense.
And then a comprehensive assessment usually involves developmental testing to understand their specific learning profile, a consultation with a clinical geneticist to discuss the diagnosis and implications, and potentially other tests depending on what features are present, maybe kidney ultrasounds if there are concerns about calcium levels, thyroid tests, hearing and vision checks.
Can it be picked up before birth?
It can, yes. Prenatal diagnosis using FAHH or microarray is possible on samples from chorionic villus sampling or amniocentesis, but it's usually only done if there's a known family history or if ultrasound findings raise suspicion. It's not a routine prenatal screen.
Right. And after birth, besides microarray and FAH, is there anything else?
Another technique sometimes used is MLPA, multiplex ligation-dependent probe amplification. It's another way to detect copy number changes, like deletions or duplications in specific targeted regions. So it's also effective for finding the Williams syndrome deletion. Routine chromosome analysis karyotype might also be done, mainly to rule out other larger chromosomal issues.
Okay, so once the diagnosis is confirmed, what does management look like? It sounds like it needs a team approach.
Absolutely. It's got to be multidisciplinary. You need input from pediatricians, cardiologists, geneticists, developmental specialists, therapists, educators, the whole team.
And early intervention seems key.
Crucial. Getting therapy started early, speech and language therapy, physical therapy, occupational therapy can make a big difference. Specialized educational support tailored to their specific learning profile is also vital.
And managing the medical side.
Yes, ongoing cardiac care is essential. Regular monitoring, medications if needed, sometimes surgery for the heart defects, and managing any other associated conditions that arise, the hypercalcemia, thyroid issues, urinary tract problems, feeding difficulties, vision or hearing problems.
What about the cognitive and behavioral aspect?
That needs dedicated support too. Social skills training can be helpful. Behavioral therapies can address the anxiety, phobias, or attention difficulties. Psychological or psychiatric input might be needed as well.
So the initial workup involves checking everything.
Pretty much. Comprehensive evaluation of all potentially affected systems. Physical exam, neuro exam, detailed developmental assessment, the cardiac workup, ECG, echo, checking the kidneys and urinary tract, ultrasound, function tests, blood and urine calcium, thyroid function tests, plus eye and ear checks.
And then ongoing.
Ongoing, it's about continuing those supports. Early intervention flows into appropriate school placement and maybe vocational training later on. continued access to therapies, speech, physical, occupational, maybe sensory integration therapy, feeding therapy if needed, especially in infancy,
Right.
regular follow-up with specialists, especially cardiology. And as they get older, continued psychological support is often important. Sometimes referral to a nephrologist if kidney or calcium issues persist.
Are there specific medications or surgeries often required?
Well, medications might include psychotropic drugs for managing significant anxiety or ADHD symptoms if behavioral approaches aren't enough. For hypercalcemia, management can range from just dietary calcium restriction to needing corticosteroids or even drugs like pamidronate in severe cases.
Surgery.
Surgery is most often for the cardiovascular issues, repairing the SVAS, sometimes other valve problems, or maybe renal artery stenosis if that occurs.
And the long-term surveillance.
Yeah, regular checkups are key. Yearly medical exams, vision screening, blood pressure checks are standard. Then periodic checks maybe every couple of years or as needed for serum calcium, thyroid function, hearing tests, and kidney bladder ultrasounds. As adults, screening for glucose intolerance or diabetes becomes important, along with continued cardiac and eye follow-up.
It really sounds like lifelong coordinated care is necessary. What's the overall prognosis?
It's variable, honestly. It really depends on the severity of the specific issues, especially the heart condition and the degree of intellectual disability. But, and this is important, with good support, medical care, therapies, education, individuals with Williams syndrome can absolutely lead happy and fulfilling lives.
But there are ongoing challenges.
Yes, definitely. Learning difficulties, social interaction challenges, and the need for support with daily living are common throughout life. And lifelong medical follow-up is pretty much always required.
Are there specific long-term health concerns highlighted in the notes?
Yes. The notes mention that those with infantile hypercalcemia need lifelong medical attention. They might have more doctor visits in infancy for various things. Then, in adolescence or adulthood, there's an increased risk of things like premature graying hair, bowel diverticulosis, diabetes, and hearing loss.
Okay.
Unfortunately, most adults with Williams syndrome do need ongoing supervision or support in their living situation and employment. Educational attainment and independent living skills tend to be lower than average. And sadly, cardiovascular problems remain the major cause of premature mortality.
That's tough. What about genetics counseling for families? You said it's mostly de novo.
Right. So for parents of a child with Williams syndrome who are clinically unaffected themselves, the risk of having another child with the condition is very low, basically the same small background risk as anyone else. Genetic testing of the parents usually isn't needed in that scenario.
But if a parent has Williams syndrome?
Then it follows autosomal dominant inheritance. So if an individual with Williams syndrome has children, each child has a 50% chance of inheriting the deletion and having the syndrome. That's a key point for genetic counseling.
Okay. And finally, just to summarize the potential hurdles, what are the main complications to be aware of?
The big ones really stem from the core features. The cardiovascular abnormalities like SVAS are a major concern. Developmental delays and intellectual disabilities impact learning and independence. Musculoskeletal issues can affect mobility or comfort, feeding difficulties, especially early on, and the behavioral challenges, particularly anxiety and ADHD.
So continuous monitoring and support are crucial for managing these.
Absolutely. Regular follow-up with healthcare professionals who understand the syndrome is vital to anticipate and manage these complications. And we shouldn't forget the psychological side, supporting their mental well-being, helping them navigate social situations, and managing anxiety is just as important.
Okay, so wrapping up this deep dive, Williams syndrome is a rare genetic condition caused by that microdeletion on chromosome 7q11.23. It leads to a really distinctive combination of physical traits, the facial features, the heart problems, especially SVAS.
Right, and the developmental delays, the unique cognitive profile with stronger verbal memory but weaker spatial skills.
And that incredibly friendly, sociable, yet often anxious personality.
Exactly. It highlights how interconnected everything is.
Management needs that multidisciplinary team, lifelong monitoring, and lots of support. But fulfilling lives are definitely possible.
Yeah. You know, what always strikes me is how this specific genetic change creates such a unique blend of strength, like the social drive, the empathy, the musicality, often seen alongside significant challenges.
Yeah.
It really makes you think about the complex pathways from genes to behavior.
It absolutely does. A fascinating condition. And if you listening want to solidify your knowledge on this or other key topics for the MSRA, definitely check out pastmsra.com.
And don't forget freemsra.com for loads of free questions and resources, too. They're both great tools.
Excellent point. Well, thanks for joining us on this deep dive into Williams syndrome. We hope you found it helpful.